day, good morning, good afternoon, and good evening to everyone. Welcome to another week of our Global Cafe sessions, the first of 2024. So wishing that everyone had a very restful holiday season and extending a very happy new year from the IFA team to everyone online. Now, back to the cafes. Today I have the privilege of introducing you all to Professor Rowan Harwood to discuss the importance of measuring healthy aging and the quality of life of older persons, which of course is a very important topic. As a little bit of a background for everyone on Rowan, he is a consultant geriatrician and professor in geriatric medicine at the University of Nottingham. Rowan's particular interests include dementia, stroke, clinical ethics, and end-of-life care. He is editor-in-chief of the journal Age and Aging and co-chairs of the WHO, the World Health Organization Technical Advisory Group for monitoring the United Nations Decade of Healthy Aging. It's truly very, very lovely to have you with us, join us today, Rowan. So thank you for your time. And with the Global Cafes, we always like to start way at the beginning with our expert online. So I'm actually just going to hand the floor over to you to share a little about your journey, professionally as well as personally, leading you to where you are now with some of your work at the university and also some of your work with the WHO.
Thank you very much, and it's a very great pleasure to be here. So I'm primarily a clinician. I'm a medical doctor. I'm trained in internal medicine and in geriatric medicine. Academically, I'm a clinical epidemiologist and an applied health researcher. So my interests have been in measuring health status and in the development and evaluation of complex interventions, the sort of things that typically older people need in addressing the problems they face. And along the way, you do various academic things like editing journals. About the year 2000, I was involved in some work with WHO about projecting the numbers of people who would be living with disability and dependency across the WHO nations. And that led on a couple of years ago to taking on this work on measuring healthy aging, supporting the UN Decade of Healthy Aging.
Thanks very much, Rowan. And I guess for a little bit of context for the audience and just to set the scene to a degree a little bit, can you just spend a few moments describing what measurement of healthy aging and quality of life actually means? And this can include things like indicators and assessment tools as well.
I suppose in answering that, we've got to go back a step. Historically, life expectancy has been the main sort of index of the health of populations. But then there's been a concern as life expectancy has increased that the years that we spend in healthy life, what's sometimes called the health span, has lagged behind the lifespan. And that leads on to big, quite fundamental questions about what is health, what is healthy aging, and following on from that, how do you measure it? How do you work out whether we're achieving it or not? Now, you could think of that in terms of freedom from disease or disability. You could think of it in terms of other things such as function or well-being. Clearly, in very general terms, we all want to live a good quality of life. Defining quality of life, of course, isn't that easy in its own right. And there's been quite an evolution over the years as to how we've thought about the dimensions of health status. The particular contribution of geriatric medicine has been to focus on the importance of function, the things that we can do. It's not the only thing. I mean, we've got to think about things like mental well-being, happiness, and the thing that has changed since 2015, is the WHO introduced a new framework for trying to think about how we conceptualize healthy aging in terms of intrinsic capacity and functional ability. And we'll perhaps come on to how those work in a bit.
Thanks very much, Rowan. And can you elaborate on where quality of life fits specifically in the context of defining healthy aging, just moving beyond medical practice?
Well, quality of life has a technical definition. It's about the value that an individual gives to their situation or their state of health. Sometimes we distinguish between general quality of life and health-related quality of life. And quality of life, expressed as a number, a utility as it's called, is a very central idea in health economics. And if we're trying to look at distribution of resources or comparison of the effectiveness of different types of medical or other therapeutic intervention, we need a common metric that we can compare between different conditions, be that hip replacement or renal dialysis or cancer chemotherapy. So quality of life fits in that space. It's a little bit problematic. It's very general. It's influenced by a lot of things other than health. So it's influenced by economics and relationships and culture and society and all the things that lead us to have a modern life. It's also subjective, and for a lot of people for whom quality of life is an issue, it is difficult for them to express subjective views. For instance, people with cognitive impairment or people with severe neurological disabilities. So there are problems as well as opportunities for the use of quality of life as a metric in healthcare. And that's why we need sometimes to break it down a little more, to think about what goes into making quality of life. There are various formulations of this. For instance, disability and distress are two dimensions that are sometimes considered. Sometimes we have multi-dimensional tools, such as the Euroqual, which lead into a single number. But quality of life is there. It's an important overriding concept, but it's quite difficult to operationalize when you're trying to monitor health or evaluate healthcare interventions.
Thank you very much. And you mentioned the subjectivity of it. So how do we overcome that barrier, particularly in measurement of quality of life?
Well, we have to stay broad-minded, and we have to know the limitations on the measurements that we're making. For example, if you look at the EQ5D, the Euroqual measure of quality of life, it has got a framework with 5 dimensions in it. There's pain, and there's everyday activities, and there's independence, and so on. And then from the point of view of doing healthcare evaluation, there has been imposed upon that a weighting system of numbers that is derived from the general population. Now, I will accord with that to the extent that I am typical of the general population. And of course, we're all individuals, and we all have our different priorities, and we all have our different values. And sometimes we value different things, and sometimes those things are quite dramatically different from one person to another. We have our different personalities, we have our different backgrounds, we have our different experiences. So strictly, to measure my quality of life, you have to ask me, and you have to do an experiment with me. And there are ways you can do that: time trade-off, standard gamble, that sort of thing. But that is very, very time consuming and not really very viable for certainly for population surveys, where you need to use questionnaire-based measures. So I think we need, quality of life is a thing, and measuring quality of life is a thing, and we can use it, and we can use it in its place, but it won't do everything for us when we're monitoring health and evaluating interventions.
Thanks very much. And Rowan, you've mentioned before that the narrative of aging has really evolved, and that it's no longer just about life expectancy, but about the quality of those years. So can you just take a few moments to further elaborate on how health systems need to adapt and address not just isolated acute health conditions, but also some of the complex intertwined issues accompanying aging, and why measuring this impact is so important?
Mm. I mean, that really brings us back to the whole narrative of how our experience of health and ill health has changed over the centuries and decades. You know, if we go back to an era not really very long ago, 100, 150 years ago, when, infant mortality was 25% and many women died in childbirth, predominantly from infectious diseases, smallpox and TB and cholera and so on. Um, the focus of public health and of health intervention was to overcome those diseases. And then in the mid 20th century, we had the rise of the non-communicable diseases, cancer, heart disease, stroke, and schizophrenia. I mean, it's not just physical healthcare that we're talking about. Um, and the models that we used for infectious diseases weren't quite appropriate anymore. Now, new models evolved. There's been incredible success in the prevention of vascular disease. There's been incredible success in making progress against cancer. But now we've got to a newer era yet. It's about multimorbidity. It's about frailty. Frailty being the vulnerability to crises and poor outcomes. Um, Possibly best thought of as an accumulation of deficits, of problems across multiple organ systems, involving multiple diseases. And the approach that we need to have to that is very different from what's sometimes called the medical model. You diagnose a problem and you treat it. So we're dealing with chronic diseases, long-term diseases, as well as short-term acute diseases. We're dealing with them in multiplicity, and we're having to deploy a whole variety of different approaches. So we have prevention. We have prevention of the complications of diseases. I mean, prevention of pressure sore is a major activity for people who are ill nowadays, and we're pretty successful at it. We have cure. We do cure things. We cure infections. We can cure nutritional deficiencies. We cure some cancers. We do manage to alter some physiology, the physiology of heart failure, or the physiology of hypoxic lung disease. We can influence some of those things, but then we need to think even broader still in terms of how we maximize function, and that makes our health approach much more multi-professional. We bring in physiotherapists and occupational therapists and speech and language therapists and dietitians. And we need to think even broader still in terms of what the social and cultural environment can do to enable or disable people. I think in our more advanced societies, as you walk down the street, you can notice all the things we do to try and make life easier for people who have various sorts of impairments or disabilities, helping people cross the road, helping people get into shops, helping people get up and down the levels of buildings. There's lots of things that we do. A lot of them are in law. They're not medical at all. So the equality legislation is very important. And similarly, we can be disabling at the same time. We can be excluding through our policies and our approaches to life. So we need to be flexible. We need to be broad. We need to deploy everything that medicine can do, but we can't be limited by medicine alone.
Absolutely. And I think you made that very clear, especially with the multidisciplinary collaborative approach that is very much needed. And I'm quite curious to know your thoughts about this, but in perhaps the low and middle income countries. So every week we have a great attendee with with a lot of incredible questions, Mr. Shmuel Yerushalmi. And this week he posed a question regarding the role of the UN and the WHO, but specifically an effective measurement of healthy aging and quality of life of older persons in lower economic kind of countries. But with that, I also just want to get your thoughts on what some of the key barriers and challenges in terms of measuring healthy aging and the quality of life of older persons, specifically in these countries, could be, because
Mm.
of course, a nation's ability to collect, analyze, and disseminate high quality data on aging and inequalities is very much crucial for all stages of just evidence-based decision making.
Yes, and I think in order to address that question, we have to think about where we get the data from that we use to monitor health. So most countries have pretty good birth and death registration. It's not always wholly accurate, but we by and large know how many people are being born and when they die. Um, you can extend that a little bit further into other forms of routine health activity data. So most places with a structured health system will be able to tell you what diagnoses are going through, what procedures are being done. There'll be a lot of stuff around activity, how many people attend a doctor, how many people see a nurse, how many people see a midwife, how often they're in hospital. And that has some limited utility in trying to monitor health. It has less useful utility in monitoring healthy aging because it's not very well aligned to the sort of things that are important for people. There are two other ways that we collect data. One is through surveys, and a survey is where you deliberately set out to measure something in a population. So you have to sample the population, you have to have a tool with which you can measure different aspects of health. And again, most economically advanced societies will do this from time to time, or they will have systems in place that are doing it on a rolling basis, on an ongoing basis. It's much less common in lower and middle income countries. A third way of doing it is through specific research studies. And there is a family of studies called the health and retirement studies. It's set out in the US in the 1990s, and there are now 20 or 30 of this family of studies which have similar methods, which can be compared, which is great, because if you're measuring one thing in one country and another thing in another country, obviously you can't compare them. So there are families of studies that set out to look at populations. However, there are 20 or 30 of those. There are 195 countries in the UN, so it's a relatively small proportion. The barriers are that measuring the sorts of things that we want to measure are resource intensive. You need feet on the ground to actually go and collect the data. You need people to analyze it, to be able to interpret it. The WHO has a long history of hosting or curating such surveys, and in fact there is one in development now called the Global Aging Population Survey, or GAPS, which will be piloted in Kuwait and Algeria very soon, and which will be an opportunity to apply worldwide a unified set of measurements for healthy aging. So the barriers are: it's complicated, it's expensive, there are competing calls on resources, and the opportunity is that I think people are more and more seeing the need for this, especially as the lower and middle income countries go through what's called the demographic and epidemiological transitions. Things like diabetes and stroke and dementia are increasingly important throughout the world because populations are aging fast.
Absolutely, thank you. And I would really like to also get your thoughts on data collection in rural populations. I see in the chat, Dr. Asha Vijay Rao, you posted this question. So if you would like to unmute Dr. Asha to pose your question to Rowan. If not, I can also just pose the question as well. So Dr. Asha posed the question of she would like to know a little more about tools to collect data from rural populations beyond those that are digital savvy, and to also address some of the language barriers that exist in rural populations.
I mean, the good news is that we've done this before, and that there is an expertise in writing. I see Dr. Asher is now on video. Absolutely, you have to pay attention to language and concepts and cultures, because things, the cultural importance of this cannot be underestimated. Ideas of ability and disability and what's normal and what support is expected are very, very culturally bound. Most of the planet is fairly digitally connected now, if we choose to make it so. There are health initiatives certainly throughout Africa, that are based on portable devices. So we're not just talking about barefoot doctors and clipboards. So we will need to use the whole armory of modern technology in addressing this. When it comes to looking at rural populations, it's going to be feet on the ground. We can't use self-report, especially where health infrastructures are relatively weak. When we come to thinking about things like function, can you walk, can you see? I mean, these are reasonably easily testable. There's a hierarchy of things here. Of course, can you see is a functional question. Why can't you see is the next level. That's a diagnostic question. And what can you do about it is a further question. And then, have you got the facility to do cataract surgery or whatever, is a further question still. So I mean, I'm not a rural health practitioner, and I would defer to those who have more expertise. Certainly the WHO does, because this is what it has done throughout its history with maternal and child health and infectious diseases, and vaccination programs. So there is a very interesting thing in this work is the amount we've learned from maternal and child health and adolescent health, where they've been through similar journeys of trying to measure some quite difficult things. I mean, if you think about adolescent health, the issues of adolescent mental health, sexual and reproductive health, which is really quite culturally sensitive in a lot of places, the interplay with education, and substance abuse and so on. So the complexities of it are there elsewhere as well, and we've learned from them. In fact, WHO is talking about a a life course approach to all these things? Can we unify things right the way through from maternal and child health through to older age? Somebody just said, what did GAPS stand for? It's Global Aging Population Survey.
Thank you very much, Rowan, and thank you very much, Dr. Asha, for your question as well.
Thank you. Thank you. Just 1 minute. I would really appreciate doctor's answer, but also, how will then you justify the data collected when you are not able to collect samples in every corner or nook corner? So how do you give percentage to the correctiveness of the data?
I mean, that's a key issue in any epidemiology, is the adequacy of your sampling, and you need to build into your system ways of validating it, making sure that you've got the right thing, and also thinking about what is an acceptable degree of accuracy or validity. Because for health policy, you don't always need to know every detail from every person. I thought you were going to say, how could you justify collecting data when you can't act to help every individual who's there? And of course, these are two separate functions. We're talking about public health here, and we're talking about whether programs to improve the population, of the health of the whole population, are actually being effective or not, and the structures and the systems. Now, that part of that will comprise individual healthcare, but it won't solely be individual healthcare. It'll be about structures, it'll be about policies, it'll be about environments.
Thank you very much, both. And I encourage folks to type any questions you have in the chat for Professor Harwood. Now, Rowan, the concept of healthy aging and successful aging can naturally be quite just controversial. So, for example, some might define healthy aging as reaching older age without disease or disability. How can we, and I know you've touched on this a little, but how can we really strive to promote and support healthy lives even after disease and disability have occurred for an individual?
Mm. Thank you. I mean, the idea of healthy aging being, a situation where you reach older age without major disease, disability, or cognitive impairment is, it as an academic exercise, that's fine. But when you actually think about that, it's impossible and it's unfair. It's unfair to sort of blame or victimize people who have suffered an illness or an injury as being unsuccessful. I'm 62. I have some arthritis, which is limiting in some extent. I still live well. I think that is the challenge, that there are conditions that we will not be able to prevent or cure. And that we need to think much more in terms of what it means to live well and how we can help people to live well, especially around conditions like dementia, chronic pain, chronic mental ill health as well. Just looking at the people on the call. I mean, there are one or two fellow older people here. I mean, as we age, we adapt, we change. Let me give you the example of my father-in-law. My father-in-law was he was an amateur musician, but he became deaf, and he really couldn't play his instrument anymore, and he took up painting. So there's an adaptation. My arthritis means I can't play tennis anymore, but that doesn't mean to say I have given up on life. You find different interests, you find different ways of living, and that will go across the spectrum of severities and abilities. So if we think about things like dementia, how can we support people to live well with dementia? There is a bit of a worry that we over-medicalize. So how do we treat pain? Well, we give drugs. but drugs for pain have problems. And we've seen problems with opioids and fentanyl and so on. So, and they're not dreadfully effective anyway. So we need to think about how do we live our lives well, despite the fact that there may be some pain in the background. Or similarly with dementia, we may not be independent anymore, but how can we live better whilst being interdependent? So we need to think much more broadly. This has come up again recently with disease-modifying therapies for Alzheimer's disease. I mean, very, very resource intensive. And to be brutally honest, what we have so far is not dreadfully effective. But there are calls in this medical model to move or make considerable changes to the way we deliver health services in order to be able to deliver drugs of minimal effectiveness. That's probably not the best we can do at the moment when we think about aspects of physical health for people with dementia, aspects of psychological and emotional well-being for people with dementia, how we best promote person-centered care that enables people to live well despite chronic conditions. And I think this is something we need to think of more and more. There's a diversity aspect to it. I think, you know, we have diverse personalities, we have diverse native abilities, but we also have diverse changed abilities when we get ill, especially when we're thinking about chronic illness and multiple illnesses, and being able to respect that is a cultural thing as much as a medical thing.
Absolutely. Well, thank you. And you mentioned person-centered care. Would you say a key aspect to achieving that is this concept of multi-sectoral collaboration amongst various healthcare professionals?
Absolutely, among various healthcare professionals, but also beyond. So there's often in many of our health systems a divide between physical health and mental health. In geriatric medicine, we're well aware of the interplay and the interaction between physical and mental health. Many physical illnesses, everything from cancer to chronic neurological disease, they have a psychological dimension to them that can be helped, that can be addressed. And we're not just talking drug therapies, but then we've got environments. We've got enabling or disabling environments, and the environment is personal and physical, but also legislative and in terms of policies and the culture. Oh, excuse me. How do we make shopping or restaurants or social activities accessible to everybody? And that takes some effort, but we can do it, and people do it. And so we need to publicize and celebrate where things are being done well.
Absolutely. No, thank you very much. And I guess just something else that kind of emerged from that when you were speaking was the concept of even the voice and meaningful engagement, which is one of the enablers of the UN Decade of Healthy Aging. So how can we, just beyond surveys, how can we ensure that the measurement of healthy aging also takes into account the voices of older persons, measuring what they want most or what matters most to them?
And that's quite a profound question and quite a challenging one, because the World Report on Healthy Aging from 2015, from which all this work derived, was to a large extent top down. It's come from what has evolved over many decades of thinking about how we conceptualize health status. There has been older participant and lay involvement in it, but as we operationalize the measures, it is particularly important that user and older persons voice is heard. And I think, you know, in WHO, they're well aware of that as an issue. I think in the health of older people, we've been more open to listening to older people's concerns, and indeed those of family and other carers, better than perhaps some other areas of medical endeavor. But it is something that we need to keep foremost in our mind, that what we are doing remains relevant to people. In some ways, what we're doing is a bit of a technical exercise. If we're saying what do we mean by healthy aging, we have to look at the and if we're going to try and measure it in a practical way, because we can overwhelm ourselves. There are thousands of different dimensions of health that we could potentially try to measure. WHO has cut it down to about 5 in terms of the intrinsic capacities. So that's mobility, locomotor and sensory, and psychological and vitality, and cognition. But then it defines these 5 dimensions of functional activity, which are really, really broad. They are well outside the biomedical. They're even beyond perhaps biopsychosocial. They're cultural as well. So this is things like maintaining relationships, contributing to society, learning, growing, and making decisions. So things which have a very broad and you might say not very medical origin. And the place, of course, the reason that they're there is that these are things that older people have highlighted over decades as being things that were important. So the voice is there. We've got to make sure it stays there, and it's not always easy, because we've got 195 countries, we've got 6 continents, we've got a lot of disparity in wealth, we've got a lot of disparity in people's articulacy, and that we've got to make sure that voices are heard from everywhere.
Thank you very much, Rowan. And I see, Dr. Asha, you posted another question in the chat if you would like to unmute to speak on it. Perhaps just giving a few moments. Hi, Dr. Asha.
Yeah. No, I just wanted to know, is there any difference between medical care, which we generally have in the hospitals, or geriatric care? Because I have been trained in geriatric care by my institute, Tata Institute of Social Sciences. But we do not have geriatric hospitals in localities, so I do not find the difference. Can you, sir, please throw some light on this?
Okay, so a hospital is one way among many of delivering medical care. We have primary care, we have aspects of long-term care, we have public health as well, which is a crucial way of making sure the population stays healthy. And I wouldn't claim that geriatric medicine is the only medical specialty that is broad-minded. Family medicine, general practice, psychiatry, rehabilitation, intellectual disability medicine, they all have a very broad biopsychosocial approach. What I do is rooted, it's based in general internal medicine. When I help people primarily by doing things to their diseases and their physiologies. That is the medical model. But what I would say is that we have to be aware that it's not the only way that we can help people's health. We don't want to disenfranchise people. We don't want to say that medicine isn't for frail older people. We're not saying that frail older people don't benefit from operations or intravenous antibiotics or intensive care units on occasions, although sometimes we overdo that. But what it is broader. So we need to think about the mental health dimension. We need to think about the functional dimension. We need to think about the social dimension. Social dimension is largely about people. It's often about families. It's often about others who are important to the individual. It's about the environment. That's what we call comprehensive geriatric assessment. There are other formulations of it in palliative medicine. They have a different set of dimensions which are overlapping. In mental health, there's ideas around recovery and achievable goals. In person-centered care, there's ideas about value and relationships and the perspective of the individual. So these are all models that we need to use
Together.
in the right place in order to get the best for the individual that we have in front of us.
Thank you, sir. Thank you very much.
And thank you both very much. And I see a question here from Eileen from Ireland, if you would like to unmute Eileen to pose your question.
Okay, thank you very much, Professor Harwood, for the fantastic presentation. The question is, you mentioned that you think there's over medication for the people with dementia and Alzheimer's, and I'm getting that perception and from listening to people who are in nursing homes. In particular, antipsychotic drugs are being used for people who keep on saying, I want to go home, especially people who are very active. And the research is also indicating that there's negative effects on people's gait and walking ability. Could you elaborate on where the research is going now at the moment, especially for older women?
Well, every drug that we ever prescribe has intended effects and unintended effects. And as the number of drugs you take mounts up, the number of things that you don't even anticipate increases as well. So you get interactions and so on. Whenever you take a drug, we have to weigh up the benefits and the burdens, and we have to assess as to whether those have been delivered or not. Has it done what it's going to try and do, and whether there is an ongoing need. Antipsychotics for agitation in dementia, by and large, don't work. I wouldn't say I never use them. I think I would be tending to try to palliate severe distress rather than to stop somebody from walking. One of the things about mental health practice and person-centered care is the exploration of non-drug means of achieving the same things. So psychosocial interventions, keeping people occupied, just tolerating things like wandering. I mean, there is no treatment for somebody who wants to walk. It's not pathological. It might be inconvenient, but we have to accommodate it. We have to supervise it. We have to keep it safe. But we're not going to stop it, short of sedating somebody into semi-consciousness, which is not healthy aging at all. It's not a good place to be. So we have to be really careful with our prescribing. Stopping and starting drugs is about the easiest thing that we do. It's not at all uncommon to see people on 5, 10, and 15 different drugs. It's very difficult to imagine that either someone will be actually taking those accurately, or that the net benefit of being on so many drugs is going to be good. If I had just had a stroke, there are probably 4 or 5 drugs that will help me in terms of preventing me having another stroke. So we've got to be, we can't be too dogmatic here and say that no older person should be on more than 4 drugs. But especially as we get frailer, especially as we approach the end of life, we have to be especially critical about what we're trying to get from our medications and what harms they might be burdens they might be causing, because just taking 10 drugs a day itself is a burden, along with the expense of prescribing and monitoring and dispensing those drugs. So it's a difficult area. We are, I'd say we haven't actually got a robust framework for managing polypharmacy yet. We have in the UK been very, very successful at getting people off antipsychotic drugs. Relatively few people with dementia are now taking antipsychotic drugs. I think in the United States, the bureaucracy around getting someone on an antipsychotic drug if they've got dementia is such that it's relatively uncommon there as well. So good question, important point. Keep discussing it.
Thanks very much. Thank you very much, Eileen and Rowan. And we are slowly coming close to the hour. So before going to the key takeaways from you, Rowan, I want to touch a little on policies. Policies are very much quite key to the path towards permanent societal change, but of course, defining successful public health policies for older adults can be difficult without reliable and meaningful data. So to ensure older adults are not left behind, how can policies better integrate data, monitoring, evaluation, and measurement of healthy aging and quality of life?
I mean, there's two aspects to that, isn't there? There's policy and there's measurement. And in passing, I'd say there's probably no such thing as permanent societal change, because it's always dynamic. We're always going to want to do better. It's always dynamic. So policies, what are policies? Well, policies will work at different levels. There will be government policies, there will be hospital policies, there will be city and civic policies, there will be professional policies. So we have guidelines, and we have regulation, all of which are important. I think the important thing is to align what those policies are doing with the health needs of frailer and older people as they come towards the end of their lives. And of course, you're not going to do that unless you're aware of it. So awareness is the key dimension. Very frequently, we introduce policies, and then there is an unintended consequence. For example, we have guidelines around osteoporosis and cardiovascular prevention and so on. And then you have somebody with multimorbidity, and they end up on 15 different drugs because 5 or 6 different set of applicable guidelines are all adding in new drugs in isolation from all the rest, when what you need is an overview. You need a holistic view and some judgment calls about what is sensible. You won't know whether policies are having beneficial or adverse effects unless you can measure something. And absolutely central to implementing any plan in government or in an organization is being able to measure whether it's doing anything, whether it's having its intended or unintended effects. And that's why we need to measure. Now, measurement will happen at different levels. There will be measures of structural things, there'll be measures of process things, there'll be measures of outcomes. And we talk about logic models now, where we can see the different levels at which things are acting. And what WHO is doing in things like the GAP survey is to try and sample at all those different levels so we can see how things are working. The thing about the WHO dimensions is, I hope they are an advance towards something which is fundamental enough to allow us to track whether progress is being made in important dimensions for older people.
Thank you very much, Rowan. And that just makes me want to ask also the question of how can we just all advocate for this, for better age-aware measurement requirements?
Well, it's all the conversations that we're involved in. We have complicated lives where we're involved as professionals and as family members and as members of civic societies. Some of us will become politicians, some of us will become civil servants, and we need that active engagement at all levels. And of course, it's not to say that maternal and child health isn't important, or that cancer chemotherapy isn't important. It's just that we need to make sure that in this very competitive environment where everyone is competing for resources and attention, that the needs of older people and indeed all disadvantaged groups are heard and are thought about. So it's in some ways it's a very satisfying technical exercise of trying to ensure fairness and equity in society. It's quite an ideological thing. It's quite a an ethical thing that we need to make sure that the particular groups are not systematically disadvantaged because of their characteristics, and that their needs have a fair calling on resources that are available.
Thank you very much, Rowan. And with this cafe session, we'd like to end things off with a few key takeaways from our expert speaker. So I would like for you to share some of your key takeaways from today's session, but with us all, please. But before doing that, I would also like to introduce everyone to next week's topic and speaker. So next week, we have the opportunity to listen to Dr. Marla Beauchamp from McMaster's University in Canada on the topic of the intersection of healthy aging and rehabilitation. I encourage everyone to join next week with Dr. Beauchamp. So back to you, Rowan. What are some of your key takeaways for us all today?
And I could say in advance that Marla Beauchamp has been involved with the WHO work as well, and she is extremely good. So a high recommendation there. So health in older people is complex and complicated, and that we need to be aware of that and to take account of it. That means that the health services we deploy have to be multifaceted and multidimensional. We need to work in teams. We need to have a bio-psycho-social cultural outlook. I think it's important to realize that we can live well with chronic conditions. We can live well with frailty and multiple conditions. And that working out how to do that best is an ongoing challenge, but it's not impossible. I think we need to think about dying well as living well. We've not really covered dying, but we will all die, and we can die well or we can die badly. Sometimes we don't get much of a choice, but it's all part of the same piece. And I'd say also be aware that there is an expertise, and doubtless, many of the people on the call are those very experts that have the expertise that can be deployed if we as societies and as healthcare systems choose to deploy it.
Thank you. Thank you very much, Rowan, for those final remarks. And before we sign off, I also just want to emphasize a very big thank you to everyone who joins the Global Cafes. You really do make them as great as they always are. And of course, a very special thank you for Professor Rowan. Your time today, as well as your expertise, was very invaluable. So thank you. Finally, a big thank you to the IFA team who not only support this cafe, but many of the other ones, and particularly Ms. Berenice Anaya. So thank you very much. Wishing everyone a great and happy weekend, and hope to see everyone next week. Thank you.